It is a privilege and pleasure to have him today on board. And he's going to be showing you live surgeries of phacoemulsification in case of ocular surface disease, as well as SLET, that is simple limbal epithelial transplantation. I'm also joined with me, the co-moderator, Dr. Praful Maharana. He's working as assistant professor in the cornea, cataract, and refractive surgery services, and also has vast experience in the field of cornea and ocular surface disease. So over to the CAR campus, Hyderabad LVPI, from which we are live. And thank you, Sayan, for agreeing to do this, for sparing your time, and for being with us today at this session, surgical session, that is the Surginar. So, Sayan, can you tell us something about the cases that you would be showing today? Can they hear us?
Dr. Namrata, can you hear me?
Yeah, I can hear you. I can hear you
excellent.
very well.
So thank you so much for the introduction. It's great to be part of this Surginar. Thanks a lot for the invitation to be part of this. And everybody who's connected this evening, I welcome you. And we are going to demonstrate two cases. The first is a allogenic cadaveric simple limbal epithelial transplantation in a case of bilateral limbal stem cell deficiency. And the second is phacoemulsification in a case of ocular surface disease with cataract. My associate Garvit will tell you a little bit about the first case that we are about to do. And if you have any questions, queries, anything that you want to ask, please feel free. And the questions, I think Dr. Namrata and Praful will relay them to me, and I'll be happy to answer while I'm doing surgery. And we'll also have a short discussion after the first surgery before the second case is shifted.
Perfect. I think we can now have somebody can tell us about the case.
Garvit?
Hi, good evening, everyone. So this is a first case is an allo slit. This is a 49-year-old female who had a Lyme injury during whitewash at home at the age of 11 years. After that, she did not undergo any surgery, and she presented to us now with right eye partial limbal stem cell deficiency in about 3 quadrants, and the other eye having total limbal stem cell deficiency with some superficial scarring. So, and you can see in the OCT her thickness is pretty much okay, but she has a lot of some anterior scarring, and we'll be doing an alloslet for this patient because we don't have any limbus available from the other eye that also has a limbal stem cell deficiency. So we'll proceed with the alloslet. Over to Dr. Sayan.
Thank you, Garvit. So, Dr. Namrata and Praful, I'm going to start surgery with your permission now.
Definitely.
So can we have the microscope view, Sayan? I think we just need to.
Can we switch to the microscope view?
No.
That's really difficult, Sayan. You can hardly see anything in that case.
So, as you can see, the patient has 360-degree limbal stem cell deficiency. There are blood vessels all around indicating that the limbus is not normal. There is some pigmentation, as you can see, patches over here, which are essentially indicative of the fact that this is a chronic sequelae of the injury. And there's also a lot of central corneal scarring. So one of the important things is, first of all, in this kind of surgery, to decide where the limbal tissue is going to come from. Unfortunately, in her case, the other eye is also damaged. So we are planning to use cadaveric tissue for her. And the pre-op preparation includes, in addition to the routine preoperative dressing and draping, that we apply topical brimonidine drops to achieve vasoconstriction. Otherwise, because of the vascularization and the inflammation in these cases, there can be a lot of bleeding during surgery. So you will see that we'll try to minimize the bleeding as much as possible, and we can achieve that by preoperative application of brimonidine. That's a very important step in all kinds of ocular surface surgeries, because bleeding is associated, and that is one of the reasons why predictability of surgery is not that great. But I will keep explaining the things that you can do to make it easy. I'm also using some special instruments. This is a scissor, which is a modified Dalk scissor that I use. It has one pointed blade and the other is a blunt one. And it also has a marking to show you for measurement, especially when you're taking a limbal biopsy. This is a 5 mm marking, which is roughly corresponds to about 1.5 clock hours. And when we start surgery, most of us are right-handed, and the dissection of the pannus is the first step here. I'll show you the limbal biopsy in a little while. So we usually start about 3-4 mm behind the limbus, and you grab the conjunctiva and the tenons together, turn the eyeball down, and make a small nick, and you dissect bluntly till you have reached the bare sclera. So this step is very important because it allows us to approach the pannus at the level of its attachment. You will also note that as I did this, there was no bleeding from the conjunctiva. And the reason for that again is that the preoperative preparation with topical brimonidine, which gives very good vasoconstriction and allows us to do this surgery with minimal bleeding. However, you will see that as we dissect closer to the limbus, there will be some bleeding, and we will need to do a little bit of cautery for that. I hope that the broadcast is and the microscope view is in focus for you.
Oh, it's perfect. It's perfect. It's looking
So,
great. Every
you know
single
what?
is focused.
Okay, great. So what we basically do is grab the pannus, use it as a handle as we approach the cornea, and we keep dissecting in this plane. And this is the plane of attachment of the pannus to the cornea. And it's a combination of sharp and blunt dissection, as you can see. So this scissor comes in very handy because when you need to cut tissue, you can use the tip of the sharp blade. And when you need to do blunt dissection, you can use the blunt blade as a spatula to do these kind of dissection where you're trying to find a plane in the cornea, etc. Another important step in this surgery is that once we have reached the cornea and that plane, it is important then next to go 360-degree and release the pannus from the limbus rather than trying to just dissect towards the center of the cornea. So if you try to dissect the pannus only towards the center of the cornea, you're very likely to buttonhole through the pannus. And then what happens is that the pannus comes off piecemeal, and it sometimes becomes very difficult to lift it off the underlying stroma. So here what we're trying to do is in the same plane, going all around. And again, you can see that because of the good preoperative preparation, you don't see a lot of bleeding happening at all. And this is something that can only be demonstrated if you prepare the patients well preoperatively. Otherwise, those of you or those of us who are accustomed to doing ocular surface surgery or even pterygium surgery will know how much the conjunctiva bleeds, especially in elderly or middle-aged people when you cut them. So what I'm trying to do here, yes, please go ahead.
Is there any specific frequency or timing for brimonidine that you use in such cases?
What is your protocol for, drops frequency?
Do
And
you use just before surgery or 1 hour, 2 hour, something like that?
So the optimal timing, so we did a study recently using OCT angiography to see what would be the optimal timing of using these drops preoperatively to achieve the maximum vasoconstriction. And similar studies have also been done using brimonidine in squint surgery. So in squint surgery also, when you are trying to do on a topical and you want minimal bleeding during surgery, they also actually they use these drops, and they found that 20 minutes before you put the incision or you cut the conjunctiva is the optimal time, because the maximum vasoconstriction is reached at around 20 minutes after putting the first drop. And you can put 2 or 3 drops. We have seen that if you put 2 drops at an interval of 5 minutes, 20 minutes before you're expected to start the surgery, that is the optimal timing, because then you get very good vasoconstriction, and the effect of the vasoconstriction actually lasts quite long, for about 2 to 3 hours. So it gives you quite a nice window to do the surgery. So I'll just show you in slightly higher magnification what we are trying to do now. So I'm going to switch from limbs forceps, which is, toothed, to a non-tooth forceps, and just do a dissection of the pannus. And you can see this is, very old injury the patient sustained almost 30 years ago. And the pannus is very thin and underlying stroma is quite scarred. But what is good about SLET is that it is not only a surgery for epithelial regeneration, but it also allows for the stromal remodeling once the epithelium has been restored. So that's a great thing about this procedure. So if you can achieve a successful epithelial restoration, then the stroma remodels and the clarity of the stroma really improves over time. So you can see a lot of the scarring regress as the epithelium becomes normal. So I'm going to use some blunt dissection using the tip of my scissors here to lift the pannus of the cornea, and rest of it we'll just scrape it off. And again, it's important to release the pannus 360-degree from the limbus so that it is easy to be lifted off. So that is basically what I'm trying to do here. You need a little bit of ambidextrity to be able to go 360-degree around the limbus, because and it is at the limbus actually that the pannus is most strongly adherent.
So
So
you are cutting with your left hand now.
yes, exactly. So these scissors also come in right hand and left hand scissors. I usually just prefer using
What
one.
is the name of the scissors, or are they something which you have designed, or are they available?
Yeah, these are called SLET scissors. They're made by Georgia Surgical, so they're available commercially. If anyone is interested in buying, they can get a hold of this. I think they are very useful in this kind of surgeries where you need to do a lot of dissection, and usually a combination of sharp and blunt dissection. So it really helps because it's not
So
always possible.
you've designed these scissors.
Yes, I have
Okay.
designed this.
I think it's a great tool, because this is
Yes.
something which we all struggle at, changing instruments after each step, because sometimes you have to dissect bluntly and sometimes you have to fine dissect.
Yeah, exactly. So these scissors are useful because you don't need to change your instruments too much, and you can do the sharp dissection and blunt dissection at the same time. So that is really useful.
Dr. San, do you
Yeah.
always go periphery to center, or you would like to modify this depending on where the exact thinning is there, or if there is severe
No,
thinning at some?
usually we always go periphery to center because the cornea, in a lot of these cases, it might be very thin in certain areas, and therefore there is a theoretical possibility that if you enter an area which is quite thin, there might be some a possibility of perforation, etc. So it is always better if we proceed from the periphery towards the center rather than going from the center towards the periphery. So outside in, always, as compared to inside out.
It also helps you to just identify that plane, because once you get the limbus and the junction of the cornea and the sclera, whether you're in the correct plane or not.
Yeah. So because this patient has had surgery, has had injury many years ago, the pannus is very compacted and very adherent to the underlying stroma. So once you've released it from the limbus, you can grab the pannus and just in different strips just peel it off, and then expose the underlying stroma and the scar in the stroma. You might sometimes have to use a 50 number blade to just scrape those layers off. I think she may have had at that point of time some deposition of the tuna in the corneal layers also. So we'll try to peel that off. And one important thing that you need to remember while doing this surgery is that your objective never is to keep removing the stroma until you reach a clear plane, because sometimes if you try to do that, you can go really deep, and that can result in a potential perforation. And you never want to be in that situation, really, when you have a perforation while you're doing this surgery, because if you are in a place like I am, where tissue is easily available, and then it's not a big deal. But if you are in your private practice and you don't have a backup tissue in hand, it can become quite problematic if you have not addressed.
So the target is
um,
just to smoothen the surface rather than achieving clarity of cornea.
yes, so the objective, like Praful correctly said, is basically to remove the pannus and expose the stoma, not necessarily to achieve stomal clarity. And we have seen this with SLET, and this has been talked about and discussed many times before, that the stomal clarity after SLET shows remarkable improvement. So once the epithelium has been restored, you can actually see that over a period of time, the cornea does clear up. So most of the pannus has been removed, and I'm just going to use a 15 number blade to remove some of the peripheral parts.
Can we center it a little bit?
Yeah, I'll do that.
So it's amazing to see the way the conjunctiva is looking kind of shocked, and then
Yes.
it's not bleeding
Not
at all.
bleeding.
Correct.
And
So if you use this protocol well, you can actually have completely bloodless surgery. And I have also done the same surgery under topical anesthesia in certain cases, where the patient did not have a fitness, etc. Those issues. So you can use a combination of this and preservative-free lignocaine, etc. to actually do ocular surface surgery under topical anesthesia also. And like I'm showing you the relative avascularity that you can see. And for especially when you're learning ocular surface surgery, I think it's very, very important to not to be discouraged by the bleeding that often happens. And one of the ways that you can prevent it very effectively is by doing this. So this is something that anyone who is starting off, particularly, I mean, I would recommend it for everyone, but particularly when you're starting off and you don't have much experience, this particularly helps. This helps a lot,
What's
because
your view on use of crescent knife?
uh, for these kind of dissections, I don't prefer using a crescent knife, because the crescent knife is quite sharp, and sometimes you can go deeper than you want to. If you are, already planned that you're going to do a dalk, then it's fine, and you are intending to go deep, and that objective is achieved. But I have seen people, particularly those who are inexperienced, go very deep because
Yes.
it's so sharp.
and crescent blade kind of makes its own plane without actually following the natural planes.
Pannus.
So it
Yes, that
creates
is true.
its own
To
plane. So
give a
that's
pseudo plane of pannus.
Okay. Now, after the pannus has been dissected to the extent that I think is enough, what I'm going to show you is two more important steps. Like I said, what stromal clarity you have underneath is not under your control. So you have to leave it at that and hope that with the epithelial reconstruction, the stromal clarity improves. Sometimes patients do very well with contact lenses. Sometimes they may need some additional corneal surgery, but mostly they do well. The second important step is to remove a frill of tenons 360-degree under the conch. This is very, very important because it allows the conch to settle back. You create some space, and this space allows you to put down your amniotic membrane well, and also allows you space to put your contact lens, and prevents the pannus from coming back too quickly. So this step, particularly in children who have, in our country, Dr. Namrata Sharma has published so much on this of tuna injuries, being so severe. This really helps because there's sometimes some tuna in the tenons also, 360, and you can remove that, and you can't basically see it, but it's there, and therefore this frill of tenons removal is very important.
So I think this is a new addition which you've made to SLET, because earlier when it was described, probably this was not described at that time when you
It
initially
was not
described.
emphasized. Yeah, we used to do it, but
Do
we
that, but
didn't
then we were emphasized that.
talk about it too much. But I have come to realize in the last few years that this is a very important step, particularly in children who have had, lime burns or lime paste burns. Okay, so we'll take the amniotic membrane.
So I think, Sayan, you showed very well that every single shred on the cornea, you removed so meticulously so that it becomes smooth completely, and there are no irregularities present on the corneal surface at all. And of course, this step where the frill of tenons is being removed 360 degrees all around.
So you see, after we have removed the tenons, the conch falls back so nicely, and you have space. So I'll show you with a repositor that you have space 360-degree to put your amniotic membrane. So sometimes, when there are attachments between the tenons and the conch, the amniotic membrane doesn't go in very well, and it can come off, it can roll out post-operatively. So if you remove the tenons, then that doesn't happen. So it gives you just more room to do more predictable surgery. That's all.
So what kind of amniotic membrane are you using? Is it the cryopreserved one? And can we use other types of amniotic membrane, the one
So
which is commercially available, and the dried, freeze-dried one? What is your view on that?
So we use the fresh frozen membrane, which is provided from our eye bank. We have very high utilization, so it's not been preserved for a very long time. Um, I think that's the best kind of membrane to use for SLED, because it's soft, it sits pretty well on the surface, adheres pretty well. Yeah, and because we are going to use glue and no sutures. The other forms of the amniotic membrane, which are the freeze dried, I think is quite difficult to use because it's a little crumbly, and I don't have a lot of experience with it, but most people have told me that it's very difficult to handle in that situation.
Difficult to handle. Also, you cannot cut it in the way that you want. It breaks.
Yeah,
It's
it
more
kind of
fragile.
it's kind of flaky. So I would suggest that to use the fresh frozen membrane as much as possible. So this is fresh membrane stored at -80. And we're now going to put the amniotic membrane. So again, because there's not too much of bleeding, I'm not going to cauterize any vessels. If you have some major bleeders that you want to tackle, you can do that too. But usually with the fibrin glue and the amniotic membrane, it will get trapped and the bleeding will stop. So this is the membrane. It's wrapped around nitrocellulose paper, and we'll just unwrap the membrane from the nitrocellulose, and we'll put it on the eye. So it's like putting basically like a sticker. So you turn it around and put it on the surface. What can happen, particularly if you don't have a lot of experience of handling amniotic membrane, is that you can lose orientation. So the amniotic membrane anatomically, it has an epithelial side, a basement membrane, and a stromal side. So we put the amniotic membrane stromal side down, and it can so happen that while you're using it, it may get all wound up and you don't know which side is which. So one of the easiest way to do that and show you is by using a Wexel sponge. So use a dry sponge, and if you touch the epithelial surface, the amniotic membrane doesn't stick to the sponge. So as you can see here, the amniotic membrane is not sticking to the sponge, but if you turn the membrane over and if you try to touch with the stromal side, you will see that the amniotic membrane becomes sticky. So you see now that the membrane is sticking to the sponge.
So I think that's a very useful demonstration, because in all the sessions that we do on amniotic membrane, this is a question, this is what is asked, that how do you know which is the correct side up? But do you think there's, suppose if somebody was to put stromal side up, do you think it's going to make any difference as far as the slit is concerned, or outcomes of slit are concerned?
I think it won't make too much of a difference in terms of the outcomes, but what the problem that can happen because of it being put upside down is that it is difficult to stick, particularly if there is some epithelium on the basement membrane side. It doesn't stick very well with glue. I mean, this is uh, very true for fresh frozen membranes, that if you try to put it upside down, then it doesn't stick very well. So that is a problem that can happen. But if accidentally, you have not been able to find out which side is which, and you have put it down upside down, and it has stuck, then it's fine. I don't think you need to obsess about it.
So, did you put the fibrin glue? So, do you take them separately, the two components, or in the
Yeah,
same?
we prepare them separately so that we can have multiple use. If you prepare them together and use the Duplojet injector that the company provides, then it's very difficult because you can use it only for one time, and we have very high utilization of the glue. So once we have taken the glue, opened it, we use it for multiple cases, and therefore, Amma, tala move cheyoddu.
Another thing that I noticed was that you've not used any cautery at all. So, do you avoid using a cautery, or
I
it's
mean,
all
in
right?
this case, as you will see, once we have put the glue and we'll put the membrane down now, you will find that there will be very little bleeding that is happening. So the fibrin itself will act as a kind of a coagulant and stop the bleeding. So it won't be necessary. But if you have, a situation where there is enough bleeding that you think should be taken care of first, then you should do that. So here what I'm doing is just ironing out the membrane and making sure that it goes under the conjunctiva 360-degree. And I'm going to take a Vexel sponge here and just clean this a bit so that it's easy for you to understand what's going on. And you will see that once the membrane
What was
is
the
in place.
instrument that you used to iron out that AMG?
So I'm just using a normal iris depositor to do that. Any blunt spatula will do the job.
And also, this ironing out dries away the blood which is there underneath the amniotic membrane to the sides.
Yes. So you will see that once I'm doing that, the blood that was collected at the limbus, as soon as we do this, it goes to the periphery. The way that you handle the membrane when you have put it down is don't use a tooth forceps because it can tear the membrane. Just use a sponge and push the globe down in the opposite direction, and then use the repositor to cut it. And whatever excess membrane frill is there, you can just trim it with a scissor.
Which type of glue preparation you prefer? Fast one or a slow one?
So this is the fast setting glue from Tissel Baxter, and I think whichever you're comfortable with. I don't know what is available commercially everywhere, or if you get to choose the setting that you when you buy it. So I think it's different from different places, but we have the fast setting. So it basically sets within the first like 15-20 seconds. So but that's not a problem. I mean, if you think that you've not put in the amniotic membrane properly, you want to go and revisit, so you can easily peel it off and put it down again. It's not too much of a problem. So here I'm just cleaning the excess glue from the periphery. And like I told you, after we have put the glue down, you can see that the bleeding automatically stops. And like Dr. Namrata was saying, if you iron out from the limbus, you will see that you can push the clotted blood that is there out to the periphery. And it then doesn't look so bad. So now we come to the most important part of the surgery, which is using the limbus. So some people often ask me how important is the limbal biopsy in SLET, and I always tell them that limbal biopsy in SLET is as important as a kidney is in kidney transplantation.
That's a good analogy.
So that is the tissue that is going to stay in the eye and work. So you have to make sure that you take good healthy limbus. For cadaveric and allogenic SLET, we use tissue that is quite fresh, uh, young donor, and you can usually visualize the limbus. So usually limbus that is pigmented, that allows us easy visualization. So I'm just putting a little bit of extra glue to make sure the amniotic membrane in one area that it seemed that it had not stuck down very well is attached. And now I'm happy with how the membrane is looking. And so I'll move ahead to the biopsy.
So, a lot of people are watching you on Facebook, and Dr. Sheetal Mahwakar is also watching, and she's saying nowadays the slow setting, I believe, is not available from the TCL, only the fast setting is available. And what makes you decide whether you're going to do a cadaveric slit or you're going to do a live related allo slit?
Well, it essentially depends on the indication, and if it's a live related is always better. A live tissue is always better than a cadaveric tissue, and within live tissue, I would say that siblings are better than parents, and any live tissue is better than any cadaveric tissue. So here you can see that this is the corneoscleral rim, and you can see the limbal tissue here. So what I do is called a snip biopsy. So you don't need to use an artificial anterior chamber. You basically just pin the corneal tissue down on one side and grab the limbus with your forceps, and you snip, and you can see from the pigmented area where the limbal tissue is, and you can just dissect in this direction and take about 1 clock hour of tissue. So you don't need to take too much. 1 clock hour tissue is fine, and that is what we'll use for the transplantation. The advantage, of course, in cadaveric is that you can always go back and take more if you think that you don't have enough.
Is there any specific donor criteria you follow for cadaveric slit?
Sorry, donor criteria?
Yeah.
Yeah, like I said, young donors, fresh tissue is very important, because the fresher the tissue is from the time of harvesting, the more likely that it will have viable cells. And that is one thing. The other difference you will see, of course, that in cadaveric limbal biopsy, the tissue looks much more bulky than you see in a live biopsy. And also posteriorly, there is more stromal component. So you will need to trim that a little bit. Otherwise, the pieces are too thick and are difficult to transplant, in the sense that they will be not sitting down properly. So that is one thing you need to take care of. Okay, so this is the tissue that we are going to use, and I'm going to now
just center it a little bit.
Yeah, I'll
towards... Yes, now perfect. No, it's gone on the other side now.
No, I'm just trying to center the microscope a little bit, because our patient is also moving around, just moving ahead a little bit. So I'm having to refocus. Okay, so this is good.
Yeah, this is perfect.
Any specific age cutoff you would like to say for this donor tissue?
So, like for the donor tissue that we use, we generally like to keep it less than 40 years.
And I would say less than 55 is okay.
Okay. And generally like to have a death enucleation DET time of, less than
48 hours, I would say. Yeah. So the way that we cut the tissue is the same. You let it hang from your non-tooth forceps. Make sure that the blades of the scissor cross the tissue. Don't try to cut it like this, nibble at the tissue, because it damages the limbus. Make sure that the blades cross all the way, and then you make a sharp cut and make a piece, and you keep repeating that. Typically, triangular pieces are the best to use. So if you can get triangular shapes, that would be ideal. I usually don't use a tooth forceps to hold the tissue, because it can macerate it, and you don't have to worry too much about the size of the tissues initially when you're cutting, because you can always resize them. And like I said in the beginning, the allogenic tissue is slightly thicker in contrast to autologous tissue, and therefore it's a little bit of a different ball game as compared to autologous limbus, because when we do live biopsies, we get very thin tissues that are very easy to cut. Here, because the stromal component is more, because we have hand dissected the limbus from the corneoscleral rim, it's a little bit more difficult to cut. So I would say anywhere between 6 to 10 pieces is ideal. You don't need to make the pieces too small. And ideally, you would want the pieces to be in the correct orientation, which is epithelial side up. So I'm just going to try and divide this piece into two.
When
And
when you're taking a cadaveric limbus, then probably the pieces are bigger. But when you're doing it from a from a auto, when you're doing a case in
From the
which you're
other eye.
taking the limbus from the fellow eye, then you think the pieces would be smaller than this. I mean, is there a
they will
censorship on the size of the
usually
piece?
be smaller also in size, because you can cut the live tissue into much smaller pieces than the cadaveric tissue, because the cadaveric tissue is more stromal component, so it's usually more difficult to divide into tiny bits.
And does it make a difference as to how you orient? Suppose if the stromal side stands up, then I mean, would you deliberately see that epithelial is up and the stromal is down, or it doesn't matter?
Well, I would prefer if the epithelium is up, because that way you can ensure that all the pieces that you are using stay. Sometimes what happens in when the pieces are upside, if the pieces are very small, then it doesn't matter. But if very small is not ideal also, because you want the pieces not to be absolutely macerated and in an attempt to make them very, very tiny. My point was that if the pieces are smaller and you can't make out which side is which, you can just not obsess about it and let it be. If you can make out which side is which, I would prefer the epithelium to be up, because what happens is that the pieces get anchored to the amniotic membrane by the epithelial cells growing out from the pieces. So if there is a delay in that process, then the pieces can fall off, because the fibrin glue stays only for a couple of days, not beyond that. So if possible, orient them the right way. If you can't make out, don't obsess about it, let it be. So I'm going to show you now how to put the fibrin glue once the pieces have been distributed. Now you can see here that each of the pieces are in the mid periphery of the cornea, and the central part has been left clear. And I'm going to use the fibrinogen component of the fibrin glue first. Just let a drop form at the tip and let that drop on the center of the cornea. Watch it distribute. Okay. And then as little drops form at the tip, you keep putting those drops on each of the individual pieces. Okay. And once this is done, then you take your blunt spatula, and this is a very important part, is that you distribute the fibrin component in between. So you fill in the blanks basically. So you distribute the fibrin component evenly over the cornea. You don't have to do it over the conjunctiva, but just make sure that the fibrin gets evenly distributed around the each individual piece over the cornea. This is important because when we are putting the thrombin component, it tends to run a bit. And therefore, what can happen is that you may have the glue collecting too much in the periphery in the fornices. But when you have the fibrin nicely spread across the cornea, as you drop the thrombin, it gels with that and it doesn't spread too much. So this is the thrombin component. It runs a little bit. So you spurt a little bit outside, then let it drop form at the tip, drop that on the cornea, watch it spread. You can see that it doesn't go beyond where we put the fibrin. And then those tiny drops you can additionally put on each of those small pieces. And after this has been done, we wait for 1 minute by the clock for the glue to gel.
So there are a few questions, and there's a question that does the size and the shape make a difference for these explants?
I would say for a 1 clock hour limbal biopsy, the ideal number is between 6 to 10. And the ideal shape is triangular. But again, in the beginning, when you're learning the surgery, it's not important to obsess about these things. But just make sure that you're not mincing the tissue too small, because that will macerate the tissue and will have an impact. And at the same time, not leaving them too big. So if you take a 1 clock hour biopsy, which is about 3 to 4 millimeters, and have only 4 pieces, that's too big. But if you have 20 pieces, that's also too small. So I would say between 6 to 10, 8 is ideal. and triangular pieces are also ideal. But even if you get a square or an oval piece, there's nothing to worry about. Those are things that, like you first, when we learn keratoplasty, we learn the big things about how to refine the graft and how to suture to close the wound and form the AC. And you learn about how making your individual sutures radial and distributed and spaced out. You learn that as you become more experienced. So those are things that you pay attention to, like aesthetics is what you pay attention to once you have mastered the surgery per se, and you can give predictable results. Those are not things that you need to worry about right at the beginning.
Dr. Syed, Dr. Praveen wants to know, is it possible to harvest stem cell from a living related donor?
Yes, of course, it is possible to do that. Absolutely. So
And
if possible,
in this case, actually, you did the panis first and you took the limbal stem cells later. But
yeah.
if limbal stem cells have to be harvested, can you first do the limbal biopsy and place, put that limbal biopsy piece in BSS and then do your panis and then.
Yeah, if you were doing a live transplant, that is what you would do. You take the biopsy first and then have the patient shifted for the panis resection and the surgery. All right. And in cadaveric, because you have the tissue with you, you can we usually do it after the panis has been resected. Okay. So I'm basically done with my surgery thin.
So in
And
this, there
I'm
was
just
some
going to.
amount of corneal opacification that was there. So have you combined, procedures like DALC or PKP with the SLEC procedure? Would you like to do that, or you think that they should be done sequentially?
Is he offline?
Are they
Video is
offline?
stuck.
Yeah, the video is frozen. So on the Facebook it is showing, but on the
वो तो delay आता है ना.
नहीं ये तो Facebook है. हाँ. So I think there is we've got stuck somewhere because the screen is completely frozen. That was a great case which was done by Dr. Sayan, and I'm sure he's going to show
Contact
you.
lens.
I think we are there now. Yeah, again. So Sayan, it doesn't matter whether you do the biopsy first or whether you do the panis first.
I would say that in live cases, you always do the biopsy first. In cadaveric, it doesn't really matter.
Dr. Sayan, if you have a choice of living related donor versus vis-a-vis cadaveric, what would you prefer?
You always choose a living donor. Give that preference.
Do you find any difference in expectance of the patient so far the outcome is there when you are using a living related donor versus a cadaveric?
I mean, living related is more complicated in terms of, the social components and the issues that come in. Who's going to be the donor? Who's going to give? And it's not very easy to give. So if, I have a case which is, I would, it's just logistically easier to do a cadaveric graft. Just use tissue which is as close to living as possible. The final thing that I wanted to show you before I took off the speculum is that sometimes you can have glue sticking to the speculum. So make sure you have a Vanna scissor in your hands while you're taking the speculum off, and just make sure there are no strands that are connecting the speculum to the surface. And if there are, then you just snip those strands instead of pulling at them. Because if you pull at it and if that strand is connected to the sheet of glue that is on the cornea, like over here, you just cut it. You can peel that sheet off or move it. So just make sure that when you're taking off the speculum, you have scissors with you and cut the strands, don't pull at them. So that's the end of the surgery, and we'll take the drape off and patch the patient and open it tomorrow. Thank you.
So Sayan, would you in some cases want to suture the